This is FX Medicine. I'm Andrew Whitfield Cook. Joining us on the line today is Georgia Marrion, who's a naturopath and nutritionist with over 15 years experience and who specialises in women's health, particularly hormonal imbalances, fertility issues and postpartum support. Now today we'll be discussing how sugar impacts female reproductive issues. Welcome to FX Medicine, Georgia. How are you going?
Thanks, Andrew. Thanks for having me. I'm great.
Okay, so I guess we start right back at the beginning. How are sugar intake and female reproductive physiology and health connected? Short question.
How long have we got?
Yeah.
But my short answer to that question is it's actually pretty complex because you need to consider the different body systems and organs and tissues that and their hormones that are involved in female physiology and reproductive and glucose metabolism, and you need to consider the bidirectional functional relationship between them, and then from there you need to consider how sugar can be impacting them individually and via how they're interconnected and how that can vary between one person and another depending on their own makeup. So that's really where the complexity comes into it, I think.
Okay, so we're well versed in thinking about the liver's issues with dealing with the conversions of sugar and the pancreas involved in insulin release. But what other tissues, organs and systems are involved? And let's talk a little bit about their interconnectedness.
Yeah, so, really here we're talking about, of course, your reproductive organs and tissues and the hormones, particularly estrogen and progesterone, although it has an effect to a degree on all of them. Your thyroid gland and your thyroid hormones, and then you're looking at largely your gastrointestinal tract and your liver. And then beyond that, it's the oxidative metabolic pathways in those various areas because they all function individually and synergistically to regulate both female physiology and to a certain degree glucose metabolism. So if you can imagine if you can imagine putting a picture in your head about this and drawing a line with each of these, it becomes a lot of arrows and a lot of lines because I actually did that. I did do that because I was doing this and this is crowding my head. So, so with your sex steroid hormones, we know that they're involved in regulating, your menstrual cycle and essentially all things being in balance, providing a environment that, that promotes fertilization, implantation, and should conception occur, embryonic development. But they also have a generally beneficial role in insulin action, your estrogens and your progesterones and glucose homeostasis, So because estrogen improves insulin sensitivity and it's involved in various processes to do with that, as well as hepatic, glucose metabolic processes. And that's a whole topic in itself, right? But then you add in your thyroid gland. So, your thyroid hormones, they have direct effect on your oocyte and ovarian surface epithelium, your endometrium, as well as your placental tissue. So it's not surprising, that your thyroid hormones, your T4 and your T3, they're involved in a lot of the molecular mechanisms that regulate things like, endometrial thickness and follicular genesis and ovulation and fertility and then embryonic development. But of course, the primary function of your thyroid gland is the regulation of energy metabolism. So of course, sugar intake and excessive sugar intake is going to be involving the thyroid gland, and then they're two big topics in themselves, but then you add in the gut and the liver. These are all quite large topics. So just to really give a broad strokes, really, I guess, is, the gastrointestinal tract and the liver, they can also have a significant impact on reproductive health and function, because your liver is involved in your steroid hormone synthesis as well as, your metabolism of estrogens and your estrogen metabolites via your phase 1 and phase 2 methylation pathways. Your liver is involved in the synthesis of your SHBG, which affects your estrogen and testosterone activity or levels and activity in the body. And then the metabolism of your estrogens are also occurring in your gut, but then your microbiome also produces a certain percentage of your peripheral T3, your bioactive T3. So, so gastrointestinal tract and liver can have a significant impact on your female physiology, but they also have a significant impact on glucose metabolism. So you can see where the complexity starts to come in.
I'm already confused. I'm thinking about patients and when we're talking about fertility issues, and we know that we are an overweight society. I get it. But many females who present for IVF are categorized, if you like, to say your weight is the issue and you need to lose weight before you'll get benefit, or that will be, you know, pushing a stone uphill until we lose weight. But what you're saying is that it could, apart from just the weight, it could be the intake of sugar that is affecting that fertility, as well as those other components.
Yeah, well, it's certainly not going to be helping.
No,
and that's the thing, right? You know, and that's,
but
you
it
know,
might be the straw that breaks the camel's back.
And that's the thing. I'm certainly not saying that sugar is the root of all evil in the whole world. But, you know, and we all need glucose. We all need, you know, your brain needs it, your body needs it to be able to function, you know. So I'm not saying no one should have any sugar at all. That's not sensible nutrition advice. But
you say that to a keto nutritionist.
No, that's it. But I mean, you know, when you've got to consider, and that, like what I was touching on before, when you're considering the environment that is within someone, and if someone is seeking assisted reproductive technology, you know, obviously something's out of balance somewhere. So you really, you know, unfortunately for those people, you know, they need to be looking at certain things a little bit closer, a little bit more detail than someone that's not have issues with conceiving. And for some women that might be sugar as a factor among several, depending on what's going on, to bring them there.
You were mentioning thyroid before, and I remember from the Bioceutical Symposium 2020, Datis Karazian was talking all about thyroid, and you got the picture in your mind that the thyroid was the driver, the cause. I've got gips going here, quotation marks, of so many disorders. But you've always got to think about, well, okay, what caused the thyroid to become out of balance? Is it only genes, or could it indeed be dietary intake, in part influenced by sugar?
So, you know, if you look at just say thyroid, you know, we know that thyroid hormone dysregulation, it can affect reproductive health, you know, as Datis touched on, and anyone in this sort of area would be aware of that, you know, because it can contribute. So with your disordered reproductive hormone profiles can lead to impaired ovarian and follicular growth, and then also follicle steroid production. But then you add it, so that can happen anyway, whether someone's having excessive sugar or not. But then you add sugar in, and that can make things worse, you know, because glucose metabolic processes and endogenous concentrations, you know, it can affect things systemically and locally in the ovaries, you know. So hypo and hyper animal models, it influenced ovarian, you know, GLUT expression, your GLUT expression, right? And then you've got your impaired thyroid function, which can contribute, you know, we were talking before how obviously it's closely involved in energy metabolism, and that can contribute to elevated glucose concentration in the ovaries, which can increase ovarian oxidative stress levels, and that can further impact on these processes, you know. So I think, you know, and that's just the thyroid.
And what about how females cope with the excessive stressors of the 21st century? I mean, being nowadays not just breadwinners, but also the caregivers, the meal preparers, the home maintenance people, you know, while guys sit there watching footy. Women do so much more. They have so much weight put onto them.
There's a lot of tabs open, I think, as a female, that I think, and this is generalizing, I think that, and it's just the way that male and female brains are generally speaking different, is that females always have more than lots of tabs open, and that's their normal. And not to say that's right, but that's how it is, compared to, you know, the male way of thinking that tends to be a little bit more singular focused, which is, you know, probably not a bad way to be when you touch on, how much I think, and I see this a lot in clinic, how much a lot of female stress is, to a certain degree, is unnecessary high expectations that we hold of ourselves, and whether those expectations come from internally or whether that comes from our perceived people's external expectations. Obviously, I guess, is another topic, but I think definitely stress, whatever is driving it. And here we're talking about sugar, but I'm yet to see a female clinic patient to do with any of these types of issues to do with fertility or hormone imbalances where stress is not playing a role.
That's right. But then you have to look back, when we're talking about sugar intake, it's not as simple as sugar intake, because then we have to think about why.
Exactly. And that's always the thing. And I think this is why I think it was important, and this is why I was curious to look into this, because you see these patients all the time, where there's excessive sugar intake happening in various ways. And I think, well, why is that happening? And how is it that one person might be presenting in a certain way, with certain reproductive imbalances or fertility issues, with, say, excessive sugar intake being a factor, compared to someone else when it's presenting in a different way. And I think that's where you've got to be taking into account all these interconnections combined with someone's own individual makeup, and that's how you can... So, but then it's interesting when you start looking at the impact of sugar on females, and we're talking about female reproductive health here, is largely, the underlying mechanisms, and it's not surprising really, but is, obviously insulin resistance and oxidative stress and inflammation in the organs and tissues that we've been talking about. So ultimately the functional and structural effects in these areas can bring on hormone imbalances, to do with levels and signaling, and then that can progress to reproductive tissue and organ dysfunction, whether you're talking structurally and then going on to functional dysfunction. And then depending on the person and how long they've had it for and what else is going on, that can then go on to present with suboptimal reproductive function and outcomes. So, and then there's a whole lot of mechanisms involved in leading to that. So, and so to pull back a little bit broader from that is that you need to consider, obviously, the person in front of you. Naturally, that's what we do in this sort of area. But when you're looking at, so are you talking about I think a more accurate way to look at it, do you have a premenopausal woman in front of you who doesn't have overt metabolic issues, or do you have a premenopausal woman who has PCOS type that's diagnosed or presentation?
Yeah.
And it's PCOS, what subtype is she? Or if it's is someone perimenopausal, and if they are, what stage are they, and how is perimenopause transition going for them? Because, say, with those sort of people, say if you're talking about PCOS women or, say, perimenopausal women, they've obviously got a particular hormonal profile going on. Say, sugar is one of the main drivers of, insulin resistance. And when they're perimenopausal, their estrogen is all over the shop, for that period of time. And estrogen, we spoke before about how, generally speaking, it increases insulin sensitivity. So when your estrogen levels are all over the shop, you can imagine the effect that's having on someone's insulin sensitivity. And then also, it's when there's issues with insulin sensitivity combined with the hormonal picture that's going on, there's a loss of muscle mass and an increase in your abdominal fat, which then also increases insulin resistance. And they also have a bit of testosterone dominance going on, just for extra measure, extra fun and games during perimenopause. And there's a bidirectional relationship between testosterone and insulin resistance, in terms of excessive testosterone can make insulin resistant worse, and so it can go back and forth. And so essentially, when those sort of women, there's someone who's in that sort of picture, she's got this hormonal picture going on, but then sugar is making that worse. So I think it's more accurate, so that her symptoms will be worse, I guess, in terms of she might always be able to she might have always experienced hot flushes, but if you add in that and the stress side of it, which can also make it worse, more severe, I should say, they're getting, their periods are heavier than they might have otherwise been. Their hot flushes are more severe and more frequent. Their energy fluctuations and mood fluctuations are perhaps more severe than otherwise. So, and then you can throw in, say, gut health, which we've spoken about, but, everyone needs good gut health, but particularly a perimenopausal woman that has estrogen levels fluctuating like she does, you need good gut health to be able to help metabolize those. So So I think it's, so I think it's more relevant to consider, if you're going to be grouping people into particular types, considering that as a broad starting point, because their hormonal picture is going to be influencing how sugar is impacting them to a degree, if that makes sense.
Well, I mean, even further patient populations, pregnant women, we've discussed women requiring fertility management, but also right down to the period that they are in their cycle. I'm surely this has got to have,
Yes,
so
for sure. And it depends on how someone, and that's why, to be fair, I did start saying it's a little bit complex. So disclaimer at the start.
Okay, I'll give you that.
So and so if someone has is getting IVF, depending on the type of fertility assistance they're getting, what's led them to why they needed to. Is it female factor? Is it male factor? And if it's female factor, what is it? Is it something that can be picked up and diagnosed, or is it something that's unexplained, which is something that's not to say it's not there, but it's not necessarily looked at in the same detail. So I think you've always got to be considering all these. I don't think there will be many women that, whatever category you're looking at putting people in, that we've been talking about, where excessive sugar intake is not having some sort of adverse effect. It just might be how it presents for them, and if it's something that is presenting in such a way that's impacting their quality of life, or whatever it is, their health that they're trying to achieve. Right.
Well, you mentioned quantities, so let's talk about the different types of sugars and indeed the quantities, because we know that sugar is one of those generalized terms that there's an inference there, but we need to be careful about what we mean by sugar.
Yeah, I think we do. And it's interesting, when I was looking at the research on this, I was a bit surprised, because it wasn't, I was expecting that it would always be fructose, and your processed fructose. But the studies that were looking and seeing effects here, it was different types of sugar that they were looking at that they noticed effects. So like some studies looked at dietary glycemic index and glycemic load, so intake of breakfast cereals and white rice and potatoes, and found that they were associated with a higher risk of your ovulatory infertility versus your low GI foods, where there was a reduced risk. Excuse me. Whereas other studies were looking at the impact of actual table sugar and soft drink and chocolate and all the fun things in life to do with, dysmenorrhea. And, and, one study was finding that, excuse me, it was more than 4 teaspoons a day that was associated with an increased incidence of dysmenorrhea, whereas a separate study found it was more than 12. And what I found interesting to do with with the more than 12 teaspoons a day, so obviously that's a pretty broad range, but what I found interesting was that the 12 teaspoons a day study, they classified moderate intake as 6 to 12 teaspoons, which is probably moderate in terms of what's actually happening, but moderate in terms of the impact, on the body, probably not so moderate in a lot of the population we're talking about. And then when we were looking at women who were going through ART, it was actually not very much at all. So they compared, sugar sweetened beverages versus artificial sweetened beverages. And obviously artificial sweetened beverages is a whole other discussion. But they were associated with lower quality and number of oocytes and top quality embryos after stimulation. And,
wow.
So we're really talking about...
That was the 6 to 12 level.
This is a separate study where they looked at 1 cup or more a day of sugar sweetened beverages versus no intake at all, had lower quality and a lower clinical rate. So this is the thing. Obviously there's other things going on as to if someone is getting ART, there are other factors going on as far as that things are out of balance and what have you. But as I said, if someone's, say, going through that sort of process, it's not going to be helping.
Well, but, I mean, you mentioned all the fun things in life, and we obviously, if somebody's got a high sugar intake, I mean, you were mentioning 12 teaspoons of sugar being the sort of upper range.
That's what they started. But the average US woman, her normal intake, moderate intake, is considered to be 8 teaspoons. So that's about 41.5 grams a day. Yeah. So
okay.
yeah.
So if, let's say, 8 teaspoons is the moderate intake, the normal intake. I hate that word, normal. That's really easily exceeded. You get a little bit of stress.
Absolutely.
You get a woman, seeing as we're speaking about women, you get a woman who has 2 teaspoons of sugar in her coffee, and if she's having 4 coffees a day, that's already your normal intake. Then you've got chocolate in the evening, some ice cream and some flavouring on top of that.
Wine. And that's not taking into account, I think, more the subvert sugar, things that are in, say, your savoury foods or your tin foods that you wouldn't necessarily, unless you're looking for it, realise that it's there. So, and I think people are becoming more educated with that now, but I mean, it very much is, and our mind works in funny ways with, the foods we count versus the foods we don't.
Okay, this is coffee, don't you?
I know that's got sugar in it. Yeah, that's it. Whereas if I drink it, well, then it totally doesn't count. So, so, and the subvert foods, like, or the savoury foods or sauces that sugar is in on top of that, the things that we associate it with, and that's where it can really add up. So I think a lot of people, if you say to them the average intake is, say, 6 to 8 a day, I wouldn't eat that much, and then you can look at it and kind of go, actually it's easier to have that much than you would think. So, and then when you consider all the healthy foods that are out, like all your raw food desserts, there's a gravitation toward that, or they much be better, but sugar is still sugar, whether it's got an organic halo over it or not. So it's still going to have the same physiological effect on your body. So, in the certain quantities. So,
well, let's go into how you actually turn this around in a tick. But firstly, how do you assess these people? Like, you've spoken about thyroid hormones. We've spoken about, stress hormones, so cortisol there. We've spoken about the impact of how the body handles sugar. So you've got insulin and blood sugar levels. So what assessments do you take or make? How many labs do you do, and what do you find are the most useful?
So I think you always got to start with the diet, particularly when we're talking about sugar, right? It's start with the most obvious spot in terms of what is their actual sugar intake, and assessing that in whichever way that someone does it in their own clinic, sort of thing, in terms of if it's a recall or food frequency questionnaire or what have you, or doing it over, say, I usually do it over 3 days. Over 3 days if you can, during a week, and then say 1 day on a weekend. So if depending on, because then their patterns tend to be
you really different. Want to take out all the fun, don't you? Yeah,
I really do. Fun police, Naturopath / fun police is my title. So but with your sugar intake, the overt stuff, that we all know, you don't need a nutrition degree to know about those ones. But then the subvert ones, like consumption of drinks, counting drinks, like we spoke about, savoury processed foods, tin foods, sauces, condiments, and that sort of thing, looking at that type of thing. And also looking at really what's driving the high sugar intake, if they're having a lot, and also if it's changed, if it's changed and, what's happened around there. So it changed 2 years ago. Is it sugar cravings? And if, and then you can unpack that a little bit more. If we're looking at dietary stuff, are they having enough protein? It's easy to eat plenty of carbs throughout the day, but I mean, are they having enough protein and good fats? Really, are they actually eating enough? Because, it's a bit of a culture at the moment of cutting out a whole food group, but it's got to be replaced with something, because your body's hormones are going to drive you to replace it with something. Are they eating enough at each meal? Is their portion control too strict? And, depending on what their physical activity levels are they eating enough to replace that? Is there a lack of energy, and is that driving the sugar intake? Or is it stress, like we touched on before? Is that what's driving it? Generally, it's a combination of factors. With a lot of women I see, is that, a combination of stress and lack of energy and sleep deprivation and wearing many hats or having many tabs open, and they tend to go with what your body is biologically driving you to get more energy and to respond to all of this input and stress. So that's the easiest thing to go for, right? So that's probably the first place I'd be looking. And then looking at your overall glycemic index and glycemic load of the overall dietary pattern, and, especially in relation to their metabolic picture and what their physical activity is, how often are they training? If are they training? If they are, how often are they doing it? And all those sort of things. And then you can look at, particular levels of particular nutrients that can be affected by high sugar intake, such as vitamin C and vitamin D and magnesium and your calcium and chromium. So you could probably start there as far as your dietary assessment and looking at those types of things. Mm-hmm. Looking at, your anthropometric measurements, with this type of thing, what's their waist circumference, what's their BMI. Obviously it's a pretty blunt tool, but, at least it's a place to record it in terms of, if there's changes or what have you, but you need to be doing it along with obviously all your other measurements.
Yep.
Obviously
do you do, by the way, a combination of BMI with hip to waist ratio, wrist assessments, that sort of thing? Do you do
I usually do BMI, obviously have their weight and BMI and a waist circumference. So, with this type of thing, because combined with, the other information you're getting from them with your assessment, and then when you're going into pathologies, you can get a good picture with that, or at least where to go next. So, and then obviously, you're not going to do all these pathologies with everybody. Some patients don't want to do any, some want to do a lot of them, but obviously you also always want to, as you said before, giving them the most bang for their buck. So what are their, if it's relevant, blood sugar parameters, obviously your fasting insulin particularly, there's no point just taking glucose if you're not looking at your insulin with this type of presentation. Your female sex steroid hormone panel, what's going on there, if it's relevant, their gut, like, dysbiosis and intestinal permeability. Obviously you can get really good functional gut tests these days that measure a lot of different parameters, so you get a really good overall picture. If it's relevant, liver, thyroid especially, and then you can look into, if it's relevant, to look at oxidative stress parameters and inflammation and vitamin and mineral status. So they're probably things that you'd be considering to see if it's worthwhile, depending on what they're presenting with and where you think things might be out of balance. That might be relevant in terms of changing your intervention or not, so, and then obviously you look at their clinical presentation.
Yeah. Just a little bit about the earlier assessments. When you're talking about, BMI, hip to waist ratio, and some other anthropometric, anthropometric? Yes.
About 3
metric, yes. Assessments. What about things like bioimpedance and the various types of things out there? I mean, you can get $8 scales that, apparently assess your lean body mass now. So how sensitive do you find these? How useful do you find these sorts of pieces of equipment? Do you need to pay the thousands of dollars for the more sensitive, forgive me, I think it might be a 6-channel bioimpedance, or can you get away with just simple measures with a tape measure and a set of scales?
Look, I think everyone, uses different tools and strategies and assessments in clinical practice. I don't use bioimpedance personally because I find it might be useful in some ways, but I think you can get a lot of information, from the sort of questions you're asking in these types of measurements that we're talking about, like a set of scales and, and being able to measure them. And should you need to, because you can look at someone and then you can look at their pathologies, and then you can I think you can get similar information. Say if someone, like if you've got someone that's, like I guess the skinny fat person, that you talk about, that, to look at them, they're lean, but then you take their pathologies like inflammation or blood glucose and what have you, and you can see that there's metabolic stuff going on. So I think you can get the same information in other ways depending on how someone likes to practice. So,
And looking at the labs, are there any labs that you tend to sort of favour as standards, like, fasting insulin, your thyroid assessments, antibodies, cortisol awakening response, for instance? That was something I found really interesting with Carrie Jones.
I did too, and to be honest, because I haven't used the cortisol awakening response before, but I think I was really interested to see what she'd observed clinically. So it's on my list of clinical tests to add.
I still have my question, I guess, with that test is, if you're going to take the normal daily, 4 tests throughout the day,
Yeah.
Via the pipette. That's the standard way of doing it, versus the cortisol awakening response, which is the short peak in the morning that you're checking. And I think you do 3 tests there. I don't know, but I wonder if, what if you just paid for that daily test if it was cheaper, but just did it here? Wouldn't you be getting just as much useful information anyway? I don't know. Haven't looked into it yet.
And I think you just let the cat out of the bag for the pathology.
That's your homework.
Yeah.
We've spoken about thyroid.
Yes.
What about things like neurotransmitters? What about the effects of, not just, let's say, histamine, or let's say GABA? Do you ever use any of the urinary marker assessments?
No, but I found that interesting with Datisa's talk at the symposium. I would like to look further into those in certain women. So, like, with some women who are hypothyroid or having subclinical thyroid issues, where there are mood issues or anxiety, and that's those sort of presentations going on. I think it would be worthwhile adding that in certain cases to dig a bit further, where there might be certain neurotransmitters having an impact on that. I wonder about that. So that's not something I've used, but I would like to.
And what about even simple stuff like blood sugar monitors are like, what, $80 odd now? Blood sugar
level. Want to be getting insulin, yeah.
Forgive me?
So you still want to be getting insulin, you have your plasma glucose, but you want to get insulin.
That's right. So do you ever use BGLs, or do you just take a fast?
I think well, if they're only going to get one test out of the 2, you go for insulin, but ideally you want to get the whole picture. It's like if you're going to get thyroid, you get a little bit from TSH, but you're not really going to get enough information that's really actually helpful. So you want to get your full thyroid panel, if you can do it. So same sort of thing with blood glucose.
And what about doing a 2-hour or even a 4-hour glucose tolerance test? Have you ever investigated these? Yes. And Dr. Mark Houston used to favour the 4 hours, and I just thought, good luck getting somebody to sit in a pathology lab for 4 hours while they're feeling like absolute rubbish.
Yes, yeah. I think I think for the most part it's probably realistic. If it's relevant to do a blood glucose, the 2-hour one, to be honest. So because as you said, you'd love to have the patient where you can have all these pathologies and have the perfect, but that's not reality. So everyone's not going to do every test, and to expect someone to do a 4-hour test when it isn't going to change your intervention is the main point. You're really only doing pathologies if it's actually changing how you would manage and how you would treat that person, rather than getting the information just for interest's sake.
What about access to these tests in Australia? Do you ever find pushback, or do you just get the patient to pay privately?
Sometimes, yeah. Sometimes there is, and often it's a cost sort of thing. But I think it comes down to how you're communicating with the patient, and it's obviously always up to them. It's very much a partnership situation in clinic, in that if I might know a lot about certain things, but then they're the expert on them. And so it's about, say, in that case, explaining, okay, what's the reasoning for the test and what we should get out of it, and how that might change how we intervene or not.
Yep.
And then it's up to them whether they decide to go ahead with it. But obviously, as a clinician, everyone's had patients where they would really find a particular test result useful, but then they decide not to go down that track, and then then you go from there. So, but sometimes there can be, but.
And do you find reticence to do these tests, particularly things like fasting insulin, with GPs, or do you just get the patient to pay privately?
Often I'll go privately, because depending on what it is that you're getting tested, say thyroid, if someone's thyroid is normal, but clinically they're not presenting as normal, getting them to get a full thyroid test can be tricky. So I often find it's a little bit easier to go, and I explain both options to them. I always say to them, go see a doctor and get, this is an option to pay for it. And then, like anything, you present the evidence and the information, and then it's up to them how they decide to proceed. Is usually how I go.
Yeah, I'm encouraged at least to see that GPs are more often screening for thyroid antibodies these days, whereas before it was just this denial. It was a blanket denial.
Yeah, there's definitely more coming out, which is good, which is good because we've all seen, in this sort of area, women who are presenting with subclinical hypothyroid issues, and they're suffering, and something is out of balance. When you look at them clinically, you don't have to take a thyroid test to know that.
Yeah,
something's out of balance. Taste sort of touched on is that the thyroid imbalances can present in so many different ways. There can be the common symptoms and common clinical presentation, but it's so varied that you can't put people in the box of this TSH above here. Well, you're perfectly normal when they're clearly not.
Perfectly normal. Yeah,
perfectly normal, even though you can't even stay awake at night, and everything's changed in the last 3 years since you've had a child. So with your hormones. So, I'm glad that there's more information coming to do with that and TSH levels.
Just tying into something you said way earlier, and that was about the microbiome.
Yes.
And Tees was mentioning this as well, that there was a substantial amount of T4 to T3 conversion, which was enabled by your microbiota. Is that correct?
Yes, that's right. So I think it's around about, and obviously it'll be varied by individuals, but they estimate it's around about 20% for bioactive T3. Yeah, which is, obviously that's going to have a significant clinical effect on people. So it goes via the similar, like it can go via the enterohepatic circulation as well. So you can imagine, like we were talking about before, gut health. Obviously, it's a fascinating area which you can talk about for hours and hours, or we could talk about.
And we're still only chipping away at the tip of the iceberg. Yeah.
Well, this is right. Yeah, exactly right. But if you even just can take gut health and the impact of that on female reproductive health, and gut health is amazing in that it's also one of those areas that, with the right interventions, you can really make a difference to people in terms of how they're feeling and what they're presenting clinically with gut health. And I think that's one of the amazing things about the gut.
Yeah. Okay. So when we're talking about sugars, we're talking about its influence on microbiota, and carbohydrates certainly are going to favour the firmicutes. How do you bother testing the gut microbiota at all? Do you just work on the diet and make sure that you've got, your sugar intake to a minimum and dietary fibre up and adequate protein and all that sort of thing?
Yeah, well, it can always, because when you're doing your gut test, you're not usually just doing your microbiome. So when it's in the context of everything else, I think it can be useful. Obviously, as far as when you're getting your stool test, it's really only giving a teeny tiny snapshot of what's actually in the gut, because that's just how testing is for it. But I do think, when you're getting a lot of the parameters to do with gut, with your intestinal lining and the parasites and all the other, and the absorption factors and inflammatory factors that they test for, I think it can give a really good overall picture when someone's presenting a certain way. So I think, not to say I test microbiome and do that for everybody, because the test is not necessarily cheap, but I think in some ways, particularly if someone's, presenting in certain ways, it can really, it can make your intervention more effective, because there's, with gut health, as we know, with gut symptoms, they can be caused by any number of things. And sometimes the fix is really quick and sometimes it's not. And when it's not, that's where having a test can be really helpful. Like, there's actually a parasite that you've had for 5 years that's really kind of showing its little head now, so to speak, clinically, so to speak.
Well, let's go further into clinical interventions. I mean, we're talking about assessment in the age of COVID-19 and the changes in practice that we've seen over the last few months. Do you find that, say, doing Skype interviews, for instance, is actually sometimes better, because you can actually ask the patient to walk you to their pantry? So there's no hiding.
Oh, it's fantastic. And also because people tend to feel more comfortable because they're in the home environment. And so you tend to get, obviously it's useful from, okay, what supplements are you taking? I'm not sure, I can't remember. Okay, can you go get it for me and hold it up to the screen? Do you know, that sort of thing? Or, you know, if they haven't taken a photo and sent it to you beforehand. But they're more comfortable. And especially, you know, because I see women largely, is that, you know, the tabs we've spoken about before and all the things that they've had to do to get to your office, you know, so there are, you know, it's another thing on their list of things to do, you know, whereas if you can do it via this way, for a lot of women, it's actually that, okay, that's one less thing, you know. So I think you tend to are more useful in some ways clinical assessment because you're getting people in their environment and they're comfortable and they're not feeling stressed. Oh my gosh, I've got so many things to do, and you know, that sort of thing. So yeah, I think it's good, the rise of telehealth, that people are more open to it these days.
And efficacy of that changes, and more than that, adherence. How do you find that works for you with helping to change these people's lives around?
Well, I think, I mean, whether you're seeing someone face to face or whether you're seeing someone by this, their motivation would be the same either way.
Right.
You know, so I think you've always got to meet someone where they're at. And obviously that's partly to do with all the stuff, all the things we've spoken about in terms of where they're at with their symptoms and their life and all of that. But also meeting them where they're at as far as what their compliance is likely to be. And that's something that, you know, I usually touch on pretty early in the piece as far as, like I said before, I know a lot of information about certain things, but I mean, I can't do it for you. I can provide you all the support and help and information, but at the end of the day, someone's got to have that motivation to make the changes that you're suggesting. So I find that's the same. Their level of motivation is the same, really, regardless of if you're seeing them face to face or in this type of modality.
Do you ever enter into like contracts with them? I remember Andrew Heyman, he would constantly challenge his patients to the point that they'd get angry with him, and he'd say, okay, so on a scale of 1 to 10, how likely are you to do this? And on a scale of 1 to 10, how likely are you to do that and that and that and that? And he just said, I will keep doing it because I want to know your level of commitment, and I can gauge what I will get out of this, if you like, how effective my treatments are going to be, or how I need to vary my treatments depending on what you're willing to change.
Yeah, and I think every clinician does it in a different way, but I think then it does need to be some communication one way or the other, whether it's, you know, that way or whether it's in a different way, as far as, okay, well, this really is very much a team effort, because it doesn't do anyone any favors to, you know, if people aren't going to follow what you suggest to them. And everyone's at different stages in their life, and they might have been really motivated to start with, and then you'll find that they're really motivated, and then they come back, and then they drop off once they start to feel better, sort of thing, and then they come back when things have gone off, and that's just the nature of how it goes. So but I think all you can do is be communicating pretty clearly about, always to do with educating people as far as, okay, and I like to do that a lot with patients as far as, okay, they're presenting this way and that's because of X, Y, Z. And so, you know, when people are empowered more with information, they're more likely to, oh, okay, so this, what I'm doing here is, you know, contributing to this, and therefore, but I find people, say women who are having hormonal issues, or if they're trying to have a baby, they tend to be pretty motivated.
So when we're changing behaviours and forgive me, I'll change that. When we're changing behaviours of intake, but you've got to be cognizant of the stressors that caused that intake to happen, which interventions do you find gives you best bang for buck?
Yes.
So like, I know this is a piece of string, I get it, but commonly, do you find that giving up the teaspoons of sugar because it's a measured dose is something that women are going to adhere to, or do you find that reducing a dose, if you like being a can of soft drink, is that the easiest thing that you can reduce their sugar intake? Or do you find that helping with food choices, enabling better food choices and cooking recipes is a way to go?
I think it's both, definitely both, and depending on what the person that's in front of you and seeing, because it's human nature. If someone says you can't have that, all of a sudden that's all you can focus on and that's all you want. you know, so you need to be working, okay, so they might have 10 soft drinks a day. Okay, well, let's look at reducing that over time and replacing that with something else. That's a better choice, you know. So, and in the meantime, let's be looking at different strategies for, okay, let's say you're having 10 cans of soft drink because it's an energy thing and that's how you're getting through your day, because you're getting 4 hours sleep a night and you've got so many demands on you. So let's look at reducing that, and let's look at supporting your energy so you have more energy so you don't have to have that quite as much. And let's look at how, you know, your gut health or your thyroid or whatever is presenting for them is also contributing to that, and doing that, whether it's, you know, obviously through diet and helping them out with that way, and then adding in supplements to help them through to bring that back in balance. So it's always a multi approach, really. You can't just, there's no point in just giving someone magnesium if you're not changing everything else. No. Or at least in small changes gradually, depending on how motivated they are and how much they've got going, because you also don't want to be adding more stress. It's always that balance between wanting to help them enough that they feel changes, but not to the point where it's causing more stress.
So how often do you have to read the riot act to the partner?
Well, it depends on the couple. I'm just going to leave it there.
Yeah. But it's a really interesting thing, and Lee and I have this argument all the time, and I'm a male. I mean, I love my barbecue. If I can barbecue, I'm in. But you and I were speaking earlier about the old joke about, you know, the woman goes and organises the children to be able to go out and do the shopping, prepare the food, cut the food up, put it into portions, season the food, and the guy puts it onto the barbecue, flips it once, and says, "Look what I cooked."
Yes, no, that's assembling. Hats off for doing the barbecue. But
do you find that partner inclusion is actually an important step about going right back to alleviating the stressors, which can be that compounding thing on
I think
drivers of...
it can be, and it depends on the dynamic of the relationship, because sometimes it can actually be, you know, the female that's holding on and not wanting to give someone else to do something because they won't do it the same way. They won't do it as well. You know, females, we tend to be our own worst enemies in that way.
Sometimes do we need to talk, Georgia? Do it.
Sometimes it's a case of, you know, where the dynamic is that the female is doing everything, and, you know, whether it's that the husband's away or that there's a certain dynamic there with that's how it's evolved. So I think it depends on the picture of that. But for females, I think often it's more the other way, where we're sort of reluctant to want to give certain things up. Because they won't do it the right way, so to speak. So I think it's, you know, I think we've got to take responsibility for that too.
Yeah. Okay, so clinical outcomes. How quickly do you find that if you can intervene, let's say in the perfect sugar restriction, how quickly do you find a resolution to have a positive outcome, like, for instance, pregnancy?
Okay, so I think pregnancy, I don't think you can put a time frame on it, because there's always, it depends on the person that you're seeing. If you're seeing someone that's, say, been trying to conceive for 18 months and there's a bit of, it's female factor infertility, but then there's male factor in there as well, and that sort of thing, obviously, you know, you can't really it's not fair to give someone a particular time frame. That's definitely by this stage it's going to happen. You know, but I think, you know, anyone in this sort of area, you want someone to give you, as a clinician, at least a 3 months for this, you know, for the quality of the eggs and the sperm, you know, but you're wanting more than that. And that's to get to your starting point of, okay, we're kind of at a bit of a baseline now, assuming that everything has been followed and what have you. Whereas if you've got someone that has, you know, menstrual issues, or someone that's perimenopausal and that sort of thing, I think interventions, you know, that we've been talking about can actually produce results, you know, quicker, you know. So like if you've got someone that has PMS types of issues, and, you know, you take them off, take them off sugar, take them off dairy, you're, you know, adding in some magnesium and B6 and things like that, you know, they can see results pretty quickly, you know, whereas someone that might be experiencing different type of fertility issues, obviously that can take longer time to unpack that, and also then going in with the right interventions that will produce the results they want.
Yeah. And what about choosing the hero I'm doing air quotation marks again, hero supplements. I know I do it a lot. But what about the hero supplements? You know, you mentioned magnesium quite a lot of time. Myo-inositol is now freely available in Australia that just wasn't available.
I know. Yes.
You know, let's say 5 years ago, except I think one product. But then there's also the beauty of herbs. So let's talk about making up a prescription. You know, what's your...
So not everyone I see would have all of these, but if someone is presenting with some version of excessive sugar intake, and how, depending on what particular system that's impacting on the most, you'd be looking at things like your magnesium for your nutrients. Obviously your magnesium, you know, your B6, your myo-inositol that you mentioned, you know, potentially looking at your lipoic acid and your zinc and your chromium. Those are the sort of things that would be in the mix commonly with women. And then you go into your herbs, and again, it comes down to really where it's being driven from. So if it's sugar cravings, you know, potentially things like St. John's wort and your herbal adaptogens. So, you know, so with, you know, your stress adrenal kind of ones, things I use, you know, combinations I use is things like your ashwagandha and codonopsis and eleuthero and rhodiola, or, you know, withania and eleuthero with schizandra and passionflower and skullcap. I find those to be good, like obviously not all together. There's sort of two different combinations I tend to use. You know, sleep support, like I'll tend to use things like passionflower and California poppy and skullcap, and kava if they can tolerate it, and hops with like a magnesium powder at night time. I like that combination. That works really well. Usually I tend to find a bit of both. So and then obviously if you've got PCOS, if it's appropriate for them, things like peony and licorice, that sort of stuff. So herbs, if you can get people to take them, especially the liquid ones, which is a discussion we usually have, where I usually quite upfront and say, okay, they're not taste very nice, but they're amazing. And, you know, to be honest, when I say that, most people are like, oh, I thought it was going to be much worse with herbs.
That's really interesting.
So we won't do any parasitic herbs.
Sorry. If you try and put a herb up, if you try and say it's not that bad, it sure as heck they're going to say it's worse. If you say they're absolutely disgusting, they're going... More often than not, they say it wasn't as bad as what I thought, as you say.
Yeah, absolutely. And to be fair, I've never given anyone, you know, your anti-parasitic herbs in liquid. I think that would be a bit mean, a bit nasty. But, you know, I find also if you tell people to have, say, a handful of walnuts or a handful of almonds after they have their herb mixture, that helps. Don't have a big glass of water because you're just prolonging the pain. Yeah, having some sort of nuts, sometimes milk, can help as well. So have that handy afterwards, and remember it's only about 2.5 to 5 mils depending on the dose you get.
Always watered down. What about things like bitter melon and indeed gymnema on its own to knock out the sugar?
Yeah, definitely, if that's appropriate for them. Like I think that can be like the gymnema can be a bit of a band-aid thing, and you know it's one of the first things you learn at herb school. First thing is and trying it, and you think, oh my gosh, that's quite amazing. Sugar really isn't that nice at all. It's like quite a I think sometimes that can have its place, but I think I'm always more inclined to go, particularly with the people that I see, you know, the sort of females we've been talking about, you know, stress is usually playing a role to a certain degree. So going down that track more so than necessarily, and I usually go with the herbs and the nutrients that I mentioned before. I'll tend to go with those. So I might add into the mixture, but I wouldn't just do a blood glucose sugar mixture. Do you know what I mean? So herb mixture, I should say.
Do you tend to combine, you know, a herbal fluid extract mixture with your nutrients in whether it be tablet or powder form, that sort of thing, to make up a...
Yeah, I will. So,
strategy?
And I try not to give people too many different things, but that's usually what I would do. The most appropriate sort of, you know, nutrient that you're talking about, and if they'll take the liquid herbs, having that as well, because you know the beauty of liquid herbs, you know, you can modify them and add them, and you can tweak them and really customize them for the person. So, but obviously it's great now. There's always the tablet version and capsule version if someone's not interested in taking the liquid. So it's good that we've got so many options these days.
Yeah. Just a quick word about caveats and responsibility of referral, I guess, when we're dealing with insulin resistance, and you know we've got a whole population of undiagnosed diabetics. We know that. It's an estimated population, which I love that. But anyway, and you've got something as simple as a blood glucose level, which if it's going to fluctuate throughout the day, okay, you may or may not have some insulin resistance. But if it's high, and you might have a type 2 diabetic, they're up in the 15s, 20s.
They would necessarily need to definitely go to their GP and get a full assessment.
Yeah, but I actually wonder if the naturopathic profession could be the vanguard of helping to diagnose and to treat effectively this unrecognised population, because nobody's looking at them.
Well, I suspect it might be, a little bit like thyroid was a few years ago, when it was really
good point.
Largely our profession, as far as that we're the only ones, and I'm talking broadly speaking, there are plenty of, holistic GPs that were looking into it as well. But like looking at, your subclinical hypothyroid people that we've spoken about, where their TSH is normal, but clinically they're presenting with thyroid and something is going on. So I suspect it's the same sort of thing with insulin now, as it's becoming more, there's more of an awareness now generally, to do with insulin resistance and looking at that. And it's not, it's not just a magic number of one thing and you're under that and you're perfectly healthy. Particularly when we look at, as Datis spoke about, all the different impacts of insulin resistance on the body beyond just weight and, and diabetes. So I suspect it might be the same for insulin and insulin resistance over the next few years.
Now, time and time again, you've mentioned thyroid, and we've also mentioned the impacts of stress on neurotransmitters. So I'm just wondering, it's a whole new podcast. There's so much more to cover. Would you be amenable to rejoining us on FX Medicine at a later date to discuss those topics?
I'd love to, yes. Sure.
Excellent. I'd love it. But thank you so much for taking us through what you've seen in clinic and indeed how you've been able to help these women. I guess not the least of which, the many tabs that your mind has. I can see you when you do it. You go like this. It's like an Indian headdress of different tabs. But I've also seen the diagram. So it's interesting to see the cogs of your mind go, but hang on. So I look forward to getting another diagram from you and delving further into the how we can help the issues of thyroid and neurotransmitter upset. So thanks for joining us today on FX Medicine, Georgia.
Thanks, Andrew. Thanks for having me.
This is FX Medicine. I'm Andrew Whitfield Cook.